Today, this is a 7-year, 1-month boy with underlying cerebral palsy with focal epilepsy under our neurology follow-up. So his cerebral palsy is
1 year old.
Sorry?
1 year old.
7 years, 1 month.
Okay. CP.
Okay. So initially, he was noted to have developmental delay since. Doctor, the presentation acutely or long?
Doesn't matter, just present.
So he initially presented with developmental delay, global developmental delay since 7 months. So at that time, noted to have fine motor and speech fine motor delays. So investigated for gross developmental delay, did MRI brain, noted to have some features suggestive of a previous cortical vascular insult. Perinatally had no events, was born late preterm 36+6. But antenatally, no, mom just had HDM and diet control, born well, no resuscitation. Postnatally, just had some jaundice for 1 day, but no NICU admission, discharged well after day 1 of life. So because of this, they also did IEM workup. IEM workup was not suggestive of any IEM inborn errors of metabolism, and genetic studies were also inconclusive. Was under OT and PT follow-up until 1 year, 8 months, he started developing seizures. So his initial semiology was right side clonic movement of the upper limb and lower limb with oral automatisms, facial twitching. So initially diagnosed with focal epilepsy. EEG also EEG at that time suggested bilateral occipital slow waves. So it started with carbamazepine at the time. Initially, carbamazepine seizure control wasn't so good. It was about 2 times seizures per week, same semiology, and he also developed some behavioral disturbances. So, with that in mind, and the poor seizure control, he was switched to sodium valproate in 2023. So, switching to sodium valproate, seizure control, nil, no seizures, and the behavioral disorders.
So they're off the carbamazepine then?
They off the carbamazepine, switched to sodium valproate in January 2023. At that time, was about 6 years old.
Then
so,
no more seizures.
Seizure control then had 1 admission in January 2023, but at that time as not status, just had breakthrough seizures secondary to poor sleep hygiene at that time, counseled for sleep hygiene, and then had no seizures until May this year. So May this year had 1 episode of seizures. Also same semiology, right side tonic-clonic with lower limb movement, lasted about 3 minutes. Parents gave subdiazepam and aborted, and they wanted earlier TCA to see that. Actually hasn't had any adjustment of the anti-epileptic since then. Today presented to us with status epilepticus. So what happened was this morning at 7 a.m. he was predictably sleeping. Ictally, video shown by father, this time the semiology is having chronicity of the left upper limb pula. Father also reports there's chronicity of the lower limb with oral automatisms. No head version, no eye version, no parallel cyanosis. Seizure lasted for 4 minutes before father gave subdiazepam. Given subdiazepam, after 20 seconds aborted. For 2 minutes, child was still drowsy, not back to usual self before seizure restarted. So because seizure restarted, they brought straight to ED. Upon arrival to ED, still having fitting. Duration still less than 30 minutes from home to ED. At that time, attended by our doctors, given another subdiazepam while waiting for the line, still not aborted, given IV midazolam. After IV midazolam, aborted. Total duration of seizures about 1 hour and 10 minutes. Throughout the episodes, his vitals were still stable, given oxygen but no desaturations even on air. Post-ictally was drowsy for about 20 minutes. Upon arrival to ward, he was already back to his usual self, active, no limb weakness, no paralysis. And then admitted to ward for observation. So upon admission to ward, he was comfortable on room air. We off the face mask already. No more fitting episodes. Further history from the parents, we noted that his anti-epileptics, he's on syrup anti-epileptics, but notes that the mother and the maid will usually give the anti-epileptics, but sometimes he will spit out the anti-epileptics. So he's not really getting the full dose. This has happened for about the past few weeks. So what happens is he'll gargle it and then he will spit it out a bit.
So how many times a week?
In a week, about 2 to 3 times, but father's unable to quantify exactly how much. But the seizure control for the past 2 weeks before that was still good. So right now, otherwise he doesn't have any intercurrent illness symptoms, no cough nor any nose. Blood investigations for this patient, no infective signs, CRP less than 0.5, Rifto at ED was 6.3, electrolytes was normal. No chest X-ray was
Specifically
done.
what?
Calcium, magnesium, phosphate all normal. Sodium was also normal, 136. Yep. Other than that, we think that he's having. So the working diagnosis for his current admission is status epilepticus. Secondary sleep hygiene has been maintained. He just has a new sibling, 2 months now. So that's
Secondary to what? They haven't finished.
Status epilepticus, secondary to underdosing of medication or disease progression. More likely underdosing of medication lah. Sleep has been quite okay actually. He sleeps from 8 p.m. to 6 a.m. uninterrupted. Just recently has a new sibling, 2 months old, and the parents have been waking up every 2 to 3 hourly to feed the child, so he also wakes up because of that. But that only happened last night. Before last night, it was okay. So that is the acute admission. His other complications for his cerebral palsy, he doesn't have any recurrent lung infections. Contractures wise, he's on rehab follow-up. No contractures. Physio being done by mother prior to having the baby, but now after the baby, not really doing physio. But he has a foot orthosis that he does use when he goes out, but doesn't use at home. Other complications, development, he's going to a hatching center, which is an EIP center. So he's doing that every day until 4 p.m. on weekdays. OTPT was every month. And then neuro follow-up is 6 monthly.
Any dystonia?
No dystonia.
Alright. Contracture don't have.
Contracture tak ada. So on examination, constipation, DO every 3 to 4 times per day, unaided, no lactulose or senna required.
How many time recurrent lung infection before?
No recurrent, never had any admission for pneumonias.
Okay, so only the seizures are the main
Yes,
problem.
only epilepsy.
So the GMFCS is what level?
So initially they didn't classify, but when we took the developmental history, this child's able to walk but with support. So father will have to hold his armpits, or he will have to hold something at the side. So for me, GMFCS is 2, but he has some fine motor disturbances. I think that could be related to the stroke. So he's 7 years old now, but not able to open bottles. Feeding wise, he's dependent on his parents. He's able to feed with his hand, but difficult for him to bring to his mouth. Cannot use fork and spoon at all. So it's fed by his parents, but doesn't need any NG feeding or thank you. So mostly fine motor is actually about, he holds pen with palmar grass. I think it's still about like 2 years developmental age. Gross motor is still 9 months to 12, 9 to 12 months. Speech, he's verbal, but only 4 to 5 meaningful words, no combined phrases. His meaningful words are papa, mama, pupu, and mamam. Can occasionally indicate when he soiled himself. So he will bring parents to toilet and then but not all the time. Sometimes he'll just bring and then he won't actually go to the toilet. So we're not really sure whether that is him knowing that lah. But he does interact with other kids at the hatching center. He interacts with his sibling, but parents keep them apart because I don't think he understands the concept of safety yet for a young baby. So other than that, speech language, fine motor, gross motor, social, feeding, dressing, he still needs to be aided.
So the CV basically secondary to what?
So, because initially it was just presented with global developmental delay and only noted this vascular query, possible vascular insult based on MRI, we think that perhaps there could be some perinatal intrapartum event that was not really noted, but this baby was born, I think, in Kajang. So we don't have the notes for that. But mom says that antenatally, no problem. She did on diet control saja. SVD, birth weight was, I think, about 2.9 kilos. Born well, no resuscitation, discharged to mom to postnatal, just jaundice for 1 day. So no significant perinatal event that we can concur. And then after that was well.
So in terms of the seizures, so what do you think if patient already 1 hour status epilepticus, what will make you want to like intubate? Already 1 hour, right?
Upon presentation, I think first I would want to know whether any PR diazepam was served, because that will guide me. And then if I have IV access, I want to give IV midazolam, 0.2 mg per kilo, and then assess the response. 5 minutes later, if there's still no response, then I would consider loading. If it's refractory, then that's when I would consider intubation, possibly for
So what I want to learn?
So in this age, Actually, because he's already on sodium valproate, I know the PIDS protocol guideline would suggest for phenytoin ataupun phenobarbital, but because he's already on sodium valproate and he's quite responsive to that, if I know that history, I think I would consider loading with sodium valproate in this case, as I think it would show most efficacy lah, because the others he would be naive towards the anti-epileptic.
The choices of
I would consider also phenytoin for this patient. Other than that, he's 7. Maybe not. Sudah.
So at what point you want to intubate?
So first line, second line, more than 30 minutes after, I would consider refractory epilepsy. Of course, consult neurologist at that point. And then intubate for possibly inducing coma for refractory status epilepticus.
Okay, so other than more than 30 minutes, what are the indication to intubate in patient with status epilepticus?
So if we want to cerebral protect, so if there's indications for that, this age group, I'm not sure, but maybe like.
So in general, other than maybe other patient, what are indication to intubate?
Impending respiratory collapse, unstable vital signs.
So at any moment of airway compromise, doesn't matter lah. Baru 15-20 minutes, you still have to intubate. Alright. Oh, and some more. What else?
Outer GCS less than 7.
Okay, but the one is very difficult to assess GCS with ongoing seizures and all that. Okay, some more? Just one more, at least. If there is an evidence of increase
or ICP.
Okay, so status epilepticus causes other than this one straightforward. You can diagnose CP, the seizures mostly related to the underlying epilepsy. But status epilepticus, other causes include?
So it can be infectious, so meningoencephalitis or abscess. It can be space popularizing lesion, any tumor or intracranial bleed also can. Then it can also be epilepsy is one. Genetic causes for younger age group, of course. Other causes for status epilepticus, drug-induced for the adolescents on any recreational drugs.
For the intracranial bleed?
So intracranial bleed, I would think
what could be the cause?
One could be scan case. So of course, the history, the quick history, any suspicious features, any bruising, any linear marks, or if there's time to do a fundoscopy, any retinal hemorrhages for a young baby, any thrombophilia, bleeding tendencies, that will also increase my likelihood of it being an intracranial bleed. Trauma. Any trauma, non-scan related.
Any metabolic causes causing ICB?
Metabolic.
No, can't remember.
I can't remember right now, sorry.
Never mind, not going to penalize you for that. But there is ICB causes, right?
Yeah, there is.
For metabolic causes causing ICB. Okay, so alright. Then if you intubate this patient, so I ask you a more difficult question. How you want to, in terms of ventilation strategy, in terms of your management in ICU with status epilepticus? How you want to cerebral protect?
Cerebral protection. So nomothermia, nomoglycemia.
What else?
Something about the carbon dioxide. I can't remember whether it's normocarbia or hyper.
If got hypocarbia or hypercarbia, what can happen to the blood perfusion to the brain?
It'll be reduced.
In what?
Sorry?
In what?
In reduced
hypocarbia or hypercarbia?
Reduced perfusion. CO2 is a vasodilator. So hypocarbia.
Hypocarbia will cause vasoconstriction, right? So then hypercarbia will increase the cerebral blood flow. So you target normocarbia. Okay, that's one. Some more. What else for cerebral protection we do?
Temperature, carbon dioxide, normal glycemia, normal electrolytes.
Yes.
Which one? Sodium.
Yeah. What about it?
Needs to be on the. If any correction of sodium, it should be done slowly to prevent any cerebral
Okay,
edema.
but given like normal sodium, but what you the aim of the treatment is there to keep a certain target. So what are the target level?
I can't remember the target level exactly.
Okay, so it's 140 and above. So anything more than 140 is fine. If you see the RP, the sodium is already going downtrend, you want to correct it. So you can give your normal saline or saline 3% to increase your sodium level lah. So because what happen if hyponatremia?
If hyponatremia, then we are worried about cerebral edema.
Yeah, you can cause a fluid shift right from the intravascular to the brain to the tissue. So if you suspect patient have cerebral edema, it's more important lah to keep your sodium level at higher level. Okay, what else? What about
the glucose, normal glycemia.
Yeah.
Then glucose, sodium, pH.
I think pH target the normal pH, but you don't hyperventilate them. So because you hyperventilate them, it cause CO2 washout, right?
Yeah.
Okay. And the degree of you want to nurse the patient.
There's something about the neck.
Not the neck lah. Just how many degrees you target?
30 degrees.
Yeah, about 30 degrees. Why? You don't want your head to be at same level as your body, so you want to prop up a bit so that
increase the. I'm not sure. I know we do it, but I forgot.
Yeah, because when you same like premature, if you keep them as flat level like that, you increase the blood flow, so causing basically you want to keep at 30 degrees, so to keep at the most optimum degree so that the blood flow will be normal. You don't want to overflow your blood to the brain, causing all this hyperperfusion lah. Same thing. That's the for cerebral protection. Is one of it is to keep it at slightly prop up patient lah. It's not very high, it's not very low. So but the thing they don't want to be at flat level lah. Basically. Yeah, I think mostly that one cover most of it lah. Okay. Right. Again, I want to ask you. So, if you notice patient have issue with the medication, so what is your plan?
So this one, because it is more of administration issue of the medication. First, I would counsel the parents on how difficult it is actually to give him. If it's very significant, so a demonstration in the ward I think would be good. So if I see that a lot of the volume comes out, perhaps I would consider that we may need to give NG tube insertion of this medication if seizure control were poor and everything. But because seizure control is okay, I think if I were to demonstrate one, we didn't do one in the ward, but if I did, I think it'd be very minimal amount that actually comes out. So perhaps.
So is it immediately child spit out?
No, he will gargle inside his mouth, play with it, and then spit a bit occasionally, sometimes of the week. Not all the time.
So what is the sodium level? Sodium valproate level?
Now it is 320 mgbd. Sorry, the presentation one was 260 mgbd, which is 27 mg per kilo per day. So there's still room to climb.
Okay, but do we send any TDM level for this one? No.
No, we didn't.
So sodium valproate got TDM. I don't think got
TDM.
TDM. Alright, that's fine. Okay.
Yeah. So I think because it's still at 27, I would consider increasing, optimizing to perhaps 30 or 35.
But given this spitting thing, you.
But because he's had this spitting thing for a while and seizure control was good. So if I want to blame that the spitting thing is causing current status epilepticus, why didn't it cause it earlier?
But you said it's happened 3 times more than the previously? No.
No. It's happening 2-3 times a week, but it's been happening for the past few months.
Okay. How's the weight? Has been gaining weight?
No, it hasn't increased. Since the last appointment till now, hasn't increased.
Therapy for this one?
Therapy less than 0.5.
Less than 0.5, so no infection as well.
Examination, lungs clear, throat not injected, so it's not an intercurrent illness.
Alright.
What to say whether it's disease progression or not, also because it's a static problem. I personally would consider repeating an EEG because previously had a right, now it's left. Perhaps it's a new foci of the seizure itself.
Neurological finding, anything new?
No, it's the same. No new neurological deficits. He's still. He actually has a bit of hypertonia on the left side. So because of the hypertonia on the left side, with some weakness on the left side, we are classifying as a hemiplegic type of cerebral palsy. But this was baseline for him.
Alright. Okay, then the other one is, I think I want to ask one more, but I forgot already. What is it? Something to do with the seizure thingy, but I forgot already. Okay, never mind. Okay lah.